Okay, good afternoon, everybody. It's my great pleasure to introduce the next speaker, Doug Altman. Professor Doug Altman graduated in statistics from the University of Bath. His first job was in the Department of Community Medicine at St. Thomas's Hospital. He's worked 11 years for the MRC, and he's a statistical consultant, and he has published widely. And he now runs a Centre for Statistics in Medicine in Oxford. And I've got an output of this meeting. I've arranged to have coffee at least once a month with Doug in Oxford at 9 o'clock. So that's my one innovation for the week, if you like, for the session. So I have the great pleasure in handing you over to Doug Altman.
Okay. Okay, thank you very much indeed. I was asked to talk to you about reporting, and in particular the impact of the way research is reported on the evidence base. And there have already been several mentions in the sessions I've been to that link into this, I think, rather nicely. So let me start by observing that reliable evidence is key to clinical practice and public health policy. Decisions in both contexts depend on having high quality information about research findings. We need research and we need reliable evidence from that research, and that means that the research has to be of a high quality, which I'm not going to address, although clearly that's not easy to define. But we also need good reporting of that research, and that is what I am going to talk about. And there's a note to myself, really, just to remind myself that although the principles of what I'm going to say apply to all types of research, I shall talk almost entirely about randomized trials. But I want it to be clear to you that what I say isn't that specific to trials. Research articles are the public face of research, and the scientific manuscripts which turn into journal articles should include sufficient information, data if you like, so the reader of that article can fully evaluate the information, how the study was done, and reach their own conclusions about the findings. Are they of relevance to them, and are they reliable? So all readers need a clear understanding of exactly how that study was done, whether they are clinicians, researchers, systematic reviewers, policymakers. We've heard about all these groups today, and indeed other groups. In some sense, this is entirely obvious, and it should be clear to people when they write journal articles that the purpose of writing a journal article is communication to the reader. It's not obvious, though, if you read many articles, that authors have that in mind. And the objective, I fear, too often is publication itself as the end process rather than communication. This is a fairly obvious idea that clinical trials will really be only as strong as the weakest element of the design, the execution, and the analysis. But clearly, if you imagine a big cloud over the front of that picture, you can't tell the quality of that chain. So, we need transparency. Poor reporting of research doesn't help anyone, and in fact, it's harmful. But by poor reporting, I mainly mean that key information about a research study is either missing, or it's incomplete, or it's ambiguous, and that can apply both to the methods of the trial and also to the results of the trial. Another possibility is that although those aspects are largely fine, the interpretation may be misleading. I'll come back to all of those issues. So let me amplify that a bit. Non-publication of research is the first thing I'm going to talk about, and that's surfaced already in the session I was at just before lunch. Non-publication of research findings will always lead to a degradation of the evidence base, because there'll be information that's missing, regardless of why that information is not in the public domain. But the main concern is that non-publication, or indeed misleading publication, will be driven by the study findings and therefore produce a distortion of the evidence base. And the most obvious example of that is the first line in black here, you know, where some whole studies are simply never published. Or possibly, less seriously, but still of concern, that some studies are published, but after some delay. We also know we have the problem of selective reporting of only some of the outcomes in randomized trials. We know, in fact, all the things I'm going to say here, that we have empirical evidence that all of these things happen, and in fact that they're quite common. And this evidence, in some instances, is quite recent. So it's not simply a phenomenon of 10 years ago, say. We have several examples of inconsistencies between data sources, between trial publications and trial protocols, or between publications and registry information. We know that many trials are published but present the data in such a way that the information is incomplete and cannot be included in a meta-analysis. And I think that is another key consideration about how research should be published, that possibility should be there. Clearly, we would be concerned about crucial aspects of research methods that have not been mentioned. And then, as I mentioned before, there's the issue of misinterpretation. Possibly we might call that spin, whereby the author's conclusions are at variance with what they actually found. And one way that's often done is by a post hoc change of focus, changing to a different outcome or a subgroup or a different time point. And lastly, not to be forgotten, is abstracts may mislead, and many more people read abstracts than read articles. At least that's what I'm told. I'm not actually sure about the evidence for that, but it seems that it's certainly true for me, and I think we need to remember that abstracts are important and not something that should be written in 5 minutes just before sending it off to the journal. So as I say, there's empirical evidence that all of these are very common things. There are hundreds of published reviews of published studies, in particular reviews of published trials. We recently published a review of 177 reviews, I think. This is big business. Most of these have been published in the last 10 years. The consequences of all of these reporting problems, not just the missing studies, but also the deficient reports of studies which are published, I believe are quite serious for clinical practice, for other researchers, for policymakers, and ultimately for patients. And it's simply not acceptable that this should happen on such a wide scale. So I'm going to give, in a minute, a few examples. Well, I'm going to do it now. And these are deliberately chosen to be recent examples that have come to my attention. So here's an example of a review of adverse events in randomized trials of HAART, that's antiretroviral therapy in patients with HIV. This is a systematic review, 49 trials. As you can see, only 16 of the trials reported all the adverse events. The other 2/3 only reported some of the adverse events. And these are quotes from the paper, either the most frequent ones or the statistically significant ones, or quotes selected adverse events, whatever that means. And these authors wrote, these facts obstruct our ability to choose HAART based on currently published data. So here we have a review. We've got 49 publications. I mean, putting aside any issues about any other studies that might not have been published, it's not possible to extract usable and useful information from these articles. These articles are not fit for purpose. Earlier this year, a review was published of trials of interventions for acute ischemic stroke over a 50-year period that it was known were completed but had not been published in full. And they found of this cohort of 904 completed trials, 20% had not been properly published. And they noted that several of those may be large enough to influence clinical practice and the findings of systematic reviews and meta-analyses. Clearly, we hope those last two things go together, really. So again, there's a major deficiency in the available information. And this one, a paper published recently looking at breast cancer, new drugs in breast cancer, a comparison of the results of trials on 3 new medicines for advanced breast cancer, comparing the publications with what the Food and Drug Administration had, showed that the analyses reported in journals were of lower quality and were given a favorable interpretation by minimizing toxicity and ignoring methodological shortcomings. And of course, anyone reading those articles, all in high-impact, high-prestige journals, would be unaware of these discrepancies from what was sent to the FDA. And in The Lancet some years ago, they said in an editorial that the idea of a drug's use being based on selective reporting of favorable research should be unimaginable. It should be unimaginable, but it isn't. And if you go to systematic reviews, I took these 2 quotes from Cochrane Reviews a couple of years ago. The first one saying there was a big problem about the quality of reporting, you couldn't judge the methodology of these studies, and the second one on data reporting, 15 trials identified for a review, but they could actually only extract usable data from 4. So the waste here is quite shocking, that these trials are done, they know about them, in many instances they were published, but they didn't give the information in a usable form. So what should be reported? Well, here's a quote from the guidelines of the International Committee of Medical Journal Editors, who say that authors should describe statistical methods with enough detail to enable a knowledgeable reader with access to the original data to verify the reported results. Now, as a statistician, I've always thought that was an admirable sentiment, but it occurred to me not that long ago that it's a very strange statement, because why are they only saying that about statistics? Surely the same principle should apply to all key aspects of research publication. The methods for selecting participants, the exact definition of interventions, outcomes, and so on. The goal here should be transparency. The paper should not mislead, and it should allow replication in principle. As a goal, I feel it should be thought in the investigator's mind, in principle, somebody should be able to repeat my study from what I tell them I did, at least as an aspiration. I realize there are practical difficulties. So some years ago, we did a review of 500 and some randomized trials published in 1 month in December, and these percentages show the percentage of trial reports that failed to report key bits of information. And I draw your attention in particular to the last 2 rows, which relate to 2 essential elements of the randomization process, because it is randomization that makes randomized trials head and shoulders above other forms of evidence. And yet here we have 4/5 of publications failing to tell you how they actually did that one step, which is the most important credibility element of those studies. And I'll come back to that review in a moment. So whose fault is this? Well, I would say that this poor reporting indicates the collective failure of everyone, of authors, peer reviewers, editors, at least, on a truly massive scale. But I'm not sure I wish to absolve other bodies like funders, medical educators, ethics committees, and whatever you might like to put in those 3 dots at the end. Now, of course, it may be that researchers don't know what information they should put in the research report, but surely then the peer reviewers and editors should tell them. But then maybe editors don't know what should be in a report either. One wonders why not, but that would seem to be the case. And so the question could be, well, what help can be given to authors? And people have been saying occasionally, at least over the last 50 years, we could do better. So the first quote here, which I think is brilliant, from 1951, basically describing, in essence, what we need to know. We need to know what was done. It's indispensable. Otherwise, you're in considerable doubt about the validity of the published work. That's what I said right at the beginning. And then Durst-Simonian in 1982 said that editors could greatly improve reporting of trials by providing authors with a list of items they expected to be strictly reported. But nothing happened really in that line until 1994. And I'm leading up to the development of the CONSORT statement, which I hope many of you are aware of. In 1994, 2 sets of recommendations for reports of trials were published. by non-overlapping groups, the SORT group and the Asilomar group. And a meeting later in Chicago in 1995 brought members of these two groups together as the Consolidated Standards of Reporting Trials group, and they sort of merged their ideas into a CONSORT statement which was published in 1996, and an update was published in 2001 with a long explanatory paper explaining what it was all about and giving examples of good practice. And the objective was fairly obvious: to facilitate critical appraisal and interpretation of randomized trials, and actually also secondarily we hope to encourage better quality trials. But I won't dwell on that. And in 2010, earlier this year, we published a revised checklist which now has 25 items, and a short paper explaining this, which we managed to publish in 9 journals, which is a story in itself, and a revised explanatory paper. It was published, amongst other places, in the British Medical Journal, which is great. Okay, so now the major changes we've made to be contemporary, we change it because the evidence base keeps changing. So now I'm talking about the methodological evidence base. We've added 3 completely new items relating to trial registration, the availability of the trial protocol, and the funding. We also clarified the issue about trial design. We've added various sub-items, in particular about changes to trial outcomes after the trial commenced, because we have empirical evidence that this is extremely common, and it's a very bad thing. We've removed something about testing blinding, and I haven't time to explain why, and we've made various things more specific, and generally simplified and clarified it, so that ultimately, of the previous list of 22 items, only 6 remained unchanged. And the other thing we did in the interest of transparency is to document all the changes we made in the publications this year. And just to give you a flavor of evolution of CONSORT, 6 papers the requirement or request was to report the planned interventions and their timing. By 2001, we changed it to precise details of the interventions intended for each group and how and when they were actually administered. And then in 2010, the interventions for each group with sufficient details to allow replication, including how and when they were actually administered, taking into account the fact that we have empirical evidence that many published trial reports don't tell you enough to allow you to implement those interventions. And similarly, for outcomes, we started with primary and secondary outcome measures. We moved on to clearly defined primary and secondary outcome measures, and we've added more words now: completely defined, pre-specified primary and secondary outcome measures, and so on. So you can see that just as medical evidence evolves, methodological evidence evolves, and the CONSORT is trying to reflect that change in that particular evidence base and keep up to date. And so I'm sure it's seen as a living document, and that we expect it to change again in the future. We have a big problem, though. We know that maybe 600 or more journals endorse and support CONSORT, but adherence remains inadequate, even for the most important aspects. So if I come back to the study I showed you before, I showed you data from 2000. Sally Hopewell led a study where we repeated this for 2006. And this plot shows that for 5 key features, which I think were on the previous slide: primary outcome, sample size, the 2 aspects of randomization, and blinding. Apart from blinding, we see a statistically significant improvement in reporting. But basically, although the percentages are not here, we've gone from 18% reporting allocation concealment to 25%. Yeah, that's a big improvement in relative terms, but we still have 3/4 of publications not telling us the one thing we most want to know about randomized trials. How did you randomize? Where is the difficulty in understanding that that's an important thing to include? And if we look at journals that do or don't endorse CONSORT, we see, again, a systematic benefit in favor of journals that do endorse CONSORT. But again, all the percentages are the wrong side of 50%. And in particular, those ones, the two about randomization, the figures are still very disappointing. So how can we improve things? Progress is there, it's evident, but it's very slow. Adherence remains poor. We must improve adherence, I believe, not because CONSORT is the last word, and I should have said, in fact, that we see the CONSORT checklist as a minimum. You know, there are many things which are not covered on that checklist which you would expect to see in a trial report if they were relevant. But authors, peer reviewers, and editors all have a role to play here. But there are no real requirements to do this, and there are no real incentives to do it, either for any of these groups, and that's a real problem. We are working on various initiatives to try to educate and try to improve uptake both at journals and by researchers. But as I say, lack of incentives is a problem. This is a picture from a paper by Deborah Zarin and colleague in Science showing the relevance of trial registration, which has been a big thing in the last few years and a very positive thing. And they show various steps. The two blue elements are trial existence and summary of protocol details. That's what you find on the trials registry. The yellow is the results database, which is now being added to the trials registry. This one here, scientific publication, that's what CONSORT addresses. And there are still two other blocks here. Access to the full protocol, access to the full data set. Anwen Chan wrote an editorial in PLOS Medicine not long ago arguing that bias, spin and misreporting, we've got to have trial protocols in the public domain. And he's actually leading a group called SPIRIT to develop reporting guidelines for protocols. But of course, that's not the same thing as publication. These documents should all be in the public domain, and they should be published before the trial is finished so that we can have full transparency when we come to look at the publication. And there are moves also to make it easier for people to publish the raw data. I realize there are difficulties in that, but at least we now have some guidance on how to prepare clinical data for publications. But even that, some people say even that isn't enough. We should go further. This is a paper by Christine Lane, now editor of Annals of Internal Medicine, and colleagues about what's called reproducible research, which I guess many of you have not heard about. And basically, the idea here is that not only do you publish the code, the protocol and the trial results, you publish the data, but you also publish the statistical code that enables you to get the results from the data. Because actually, a lot of things happen between the data file and the tables you might see in a journal article, which are not documented. And this is a way of basically putting the whole thing on the record. Another thing they do, and the BMJ I think also, is ask authors what they're willing to share with other people. The protocol, the data, indeed the source code for the analyses. Now most people will say nothing, but at least every time they publish they're being asked this question. And as with CONSORT, which has taken 14 years to get to where it is, progress is happening, but it's happening very slowly. And I think people's awareness of these issues needs to precede a big change in behavior, if we can even manage to achieve a big change in behavior. Just want to mention the Equator Network, which we set up, which is a resource for information about reporting of all types of research, not just randomized trials. And we have this website, the address in a minute, and I will end by showing a slide I always end with, which says this: good reporting is not an optional extra, it's an essential component of doing good research. Thank you.